Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Now we're both whispering. Today we're going to talk about the Columbus 7-year data. It might be one of the only targeted therapy podcasts we've done so far. Can't even think if we've done another one outright, though obviously we invoke targeted therapy quite a bit. But maybe before we do that, we've heard from so many of our guests about how they got into oncology. I certainly told you my story at one point, but I'm not sure, James, if we've heard your story about wanting to be a doctor, but ultimately an oncologist.
Yeah, maybe I'll do wanting to be an oncologist. I mean, wanting to be a doctor, I did a very scientific undergraduate degree in Cambridge, no patient contact or anything like that at all. And I sort of could have seen myself as a scientist, honestly. But then I went to do clinical medicine, and here we are, I suppose. But oncology, yeah. So when I was at medical school in Oxford, this is for the clinical part of the training, second 3 years, there was this amazing neurologist called John Newsom-Davis. Actually, his son, Tom Newsom-Davis, is a medical oncologist as well, as it happens. Anyway, John Newsom-Davis did a load of the early work on myasthenia, and he was just an absolute force of nature, not just scientifically, but clinically. So when we were learning neurology as medical students, and he was trying to teach us different gait abnormalities, he would actually do them himself. So like the clinical teaching would be, this is a such and such a gait. And he was an incredibly inspirational figure. So there's a load of people that went to Oxford Clinical School that want to be or have become neurologists because of John Newsom-Davis. So I wanted to be a neurologist. And in my undergraduate degree, I'd done quite a lot of stuff which was sort of related to, learning, memory, cognition, that sort of thing. Anyway, rat neurobiology as well. Anyway, so I do my house jobs and everything else. I do neurology, and I really enjoyed it, and I still like neurology now. But I just couldn't see myself, honestly, as doing a career in neurology. And at the time, it felt that a lot of it was about diagnosis. A lot of the diseases, unfortunately, were either not treatable or there wasn't really any effective treatment. And although I enjoyed my time doing that, I wasn't really sure it was right for me. So then I kind of passed my exams, did a few different jobs, still didn't really know what to do. Did intensive care for 6 months. That's what you do when you don't know what to do. I loved it. I just absolutely loved doing intensive care. It was just fantastic. At the Middlesex Hospital in London, so they had an amazing intensive care unit. They had a load of really inspirational people as well. Anyway, so still didn't really know what to do. And I remember this very clearly. I was sitting after a shift on intensive care with my then girlfriend, now wife, in the pub outside UCH, Jeremy Bentham, now knocked down as well. And Emma said to me, "Oh, James, why don't you try oncology?" Because I'd actually done 3 months of oncology by chance in an earlier placement, actually the Hammersmith Sapna, with Jonathan Waxman, who's a big kind of prostate person, and I'd quite like that actually. And she said, and I'd sort of forgotten about it. And she said, "Oh, well, why don't you try oncology?" And I said, "Oh, all right." And at the time, I was thinking, I'm not really sure. I was even, a lot of my friends from college are management consultants and stuff like that. And I was even thinking about applying to McKinsey for a job, but let's not go down that one now. Yeah. So I applied for an oncology job at the Marsden. This is late 99. And then I get the job, the SHO job, come and work at the Marsden February 2000. Martin Gore is my boss. Meet Martin. That's it. Changed my life. Off we go. And so he inspired me then. He was doing renal and melanoma. This is back in the day, 25 years ago almost. And I just thought this is a fantastic blend of science and patient care and compassion and everything else. And we see people at a time in their lives that they never forget. And, with all due respect for other medical specialities, I'm not sure everyone can say that. So yeah, I've particularly enjoyed the kind of the mixture of science and clinical care, and it's really interesting, and it's still interesting now. And
Yeah.
fine, I know I've talked a lot, but the other thing is that the impact of science on oncology in the last 20 years has just been astonishing. And again, other medical specialities might say the same thing, but I'm not sure that any other area of medicine where the science has really translated so clearly into patient benefit over the last 20 years.
And quickly, right? The impact of the science we do reaches the bedside quickly, which is so cool. Yeah, I mean, it ends up being the number one, number two thing funded by governments for research, for medical research, cardiology, oncology. So what I take away from that story is we really have your wife to thank for this, because she's the one that reminded you.
I have my wife to thank for a lot of things, of course.
Yeah,
It goes
there we
without
go.
saying.
Good answer. Very, very good answer. And shout out to Hammersmith and Professor Jane Apperly, who took very good care of me as I was a student there, or I was a resident there for a month, almost 2008, 9, 10. Almost 15 years ago now, I think, is the math on that.
No,
Oh,
you were at school,
you're
weren't you,
right.
15 years ago?
It was 5, 6, 7, 8. It would have been 2007, fall of 2007, so 17 years ago. Yeah, nice.
Wow.
All right, so shall we talk Columbus 7-year data?
Yeah, why don't I'm looking at the EJC publication. Let me just get the dates correct. So earlier this year, online, April 24, lead author Dirk Schardendorf, senior author Paolo Ascietto. So, I mean, I guess the thing is that this is 7-year follow-up of encorafenib plus binimetinib versus vemurafenib or encorafenib, so 3 arms, in BRAF, metastatic BRAF mutant melanoma. So I suppose this is, one of 3 approved combinations for treating advanced BRAF mutant melanoma. I think the earlier publications, there were a couple. One was in Lancet Oncology, certainly. I think it was in 2018. But this is 7 years of follow-up. So that's pretty important. What's to say? Maybe I suppose if we go to table 1, and this is interesting, I think, one of the things that the authors have concentrated on is the people who've got long-term benefit from the treatment, which I guess is one of the questions that we have in clinic. I think the earlier stuff's pretty well documented, not just for encobini, but for Vemcobi and for dabrafenib and trametinib. So this is people who were in CR or PR at this 7-year time point. And it's not a big number, actually. If you look at this, it's 34 patients altogether in CR or PR. Out of the total number of patients in the trial, which was 577. So I guess that's around about 5%, just over 5%. So anyway, so of the 34, 11 were on encorafenib monotherapy, 3 were on vemurafenib, that was the control arm, of course, and then 20 were on encobini. It's quite a big table, this. It takes up a whole page.
Yeah.
And obviously this is an exploratory analysis, and you have to be pretty careful about comparisons and statistics and everything else. I think for me, though, Sapna, I'd be interested to see what you think, but it confirms, I think, what we've seen from other data sets. Most of these people who are getting really long-term benefit have got what you might call good risk metastatic disease, low burden, normal LDH, good performance status, etc., etc., etc. Before I stop talking, though, the thing that kind of interests me, and it's a question I always have in clinic for these people who are on targeted therapy for very long periods of time, is whether or not they'd had immunotherapy first and whether this is a kind of delayed benefit from immunotherapy. So the thing that sort of jumped out there, just scrolling right to the very bottom of the table, any patients who'd had immunotherapy before they've gone on to treatment in the trial. And again, these are pretty small numbers. And if you look across the kind of the rows there at the bottom, it's basically 12 patients out of the 34. So around about a third of these had immunotherapy before, a lot of which is actually interferon. There's a tiny little bit of IPI as well.
Yeah.
So then when I read this, I went back and I thought, oh, that's interesting that a third of the patients had some sort of immunotherapy before, albeit probably a lot of it was adjuvant interferon, actually. So then I went back to the Lancet Oncology paper, wondering whether there was a sort of enrichment for people that had prior immunotherapy, but I don't think there is, actually. If you go back to the original baseline characteristics, it's a similar proportion. So I think this is reflective of the population of patients that went into the trial at the start. Quite a lot of European sites, quite a lot of usage of adjuvant interferon. So I don't think we can read too much into that, actually.
Yeah, I mean, I agree with all of that. The fact that it's a small number of patients at the 7 years and the stratification that they were doing by M category, and then by what else were they doing it by? I don't know, ECOG status. And then it says by previous first line immunotherapy, yes or no, that was a stratification. But like you, I'm not really clear if that first line immunotherapy means adjuvant immunotherapy, such as interferon that we're seeing in this table, or first line immunotherapy for metastatic disease, in which case I'm not getting a real handle on that stratification. But I think, as you're alluding to, it's probably because there are small numbers here. It's just really, really small, the people who had previous. And then the sort of flip side of that is the number of people who go on at progression to have PD-1 based therapy. Many people do go on to PD-1 based therapy, but what they don't seem to go on to is combination therapy. So that just speaks to the time and when this trial was sort of being developed. But maybe just as a bit of background, I can just explain that this was a 1:1:1 randomized study of encorafenib plus binimetinib at what we come to know is full dose. So 450 milligrams once daily of encorafenib and 45 milligrams twice daily of binimetinib, or encorafenib 300 milligrams once daily, or vemurafenib 960 milligrams twice a day. And so they were really comparing themselves, obviously, to this vemurafenib BID arm. But the reason the encorafenib dose is lower in that single arm, and the reason they even had to have that single arm, there's two things here. The reason the dose is lower is that in the phase 2, they realized that tolerance to encorafenib was better when you added the MEK inhibitor. I mean, to those of us who know this area, that's obvious. That's with all BRAF inhibitors. They're better tolerated with their companion MEK inhibitors. And so therefore you can use a higher dose. And when you use the BRAF inhibitor alone, it looked like this lower dose was better tolerated. And that's partly why you see the encorafenib dose not being matched for dose in the single arm. But the reason they even had to have an encorafenib monotherapy was really at the behest of the FDA, who said we need to see the contribution of encorafenib. So if you just did oncobini versus VEM monotherapy, we're not really sure if you just have a more potent BRAF inhibitor or if there's some contribution of this MEK inhibitor. And lo and behold, we get to this 7-year data. And I'm interested in your take on what you think the contribution of the MEK inhibitor is here. Looking at encorafenib at 300 and then looking at oncobini, very, very small numbers. So we're just having fun here, but we're also being scientific about it. We're having fun and being scientific at the same time. When I look at overall survival, and I see that not only is there not really a difference in onco as a monotherapy, but also compared to combination oncobini, the curves cross. So really, there's no statistical difference here. So then is MEK inhibitor just a lovely toxicity management? It's like a support medication here. It's helping us manage oncotoxicity, but is it really giving us efficacy here? What do you think?
Well, if it is something that quote unquote just improves side effects, there's nothing wrong with that, would be my first comment. I'm going to concentrate on figure 1A, if I may, rather than figure 1B, which is the PFS, which I think, I think the difficulty with OS here is going to be subsequent treatments and all that kind of thing. And I'd just be a little bit reluctant there. But if we just look at figure 1A, and there are hazard ratios here and landmarks at year 7. So Enco-Bini versus VEM, that hazard ratio is 0.51 for PFS. That's a very clear result. And then if you look at Enco-Bini versus Enco, hazard ratio is 0.77, confidence interval 0.6 to 0.99. So I think that kind of answers the question, honestly, that there is a benefit, I think, in terms of efficacy, but clearly the encorafenib is doing most of the work here, and I think you can say that from looking at the encorafenib monoarm. So I think there is some additional benefit, certainly in terms of PFS. In terms of toxicity, we know pretty well anyway, don't we, that MEK inhibitors will ameliorate, BRAF inhibitor toxicity and allow you to dose more. So that's sort of my take home from that. I mean, I suppose the other thing is they show melanoma specific survival in figure 2. I mean, I sort of think that's a reasonable thing to show, but on the other hand, we know here with this type of treatment, honestly, it's rarely a curative treatment in terms of competing risk. And so we talked about this with checkpoint inhibitors, where we know that there's a fraction of patients who are cured. So it feels to me that situation with checkpoint inhibitors at these longer time points, melanoma specific or disease specific survival is more relevant, with all due respect, than it is here. So those are my kind of takeaways, I suppose, in terms of efficacy. The table 2, Lisette, gone.
Oh, sorry. No, I was just going to ask you, is that one way of saying that as we look at these, you could look at this and say there's a tail of the curve. The other, if we went back and read the 5-year Columbus results, I think we would see the 5-year landmarks are, a little bit higher. I guess what do you think? Do you see a tail here? Do you think it's a tail that approximates what we get with checkpoint inhibitors, or it's not? These have different cure fractions.
Yeah, I don't know the answer to that, but it's a really important question. I think there probably is a group of patients actually who really are getting durable long-term control. We can see that here. These are patients who are basically still on treatment, though. I mean, that's the other obvious point to make when we're comparing checkpoint inhibitors, and which leads to a really important question for clinical practice. We've all got these patients in our clinic who've been on BRAF targeted therapy for very long periods of time, over 5 years sometimes. Some of it might be vemurafenib monotherapy from the really early days, dabrafenib, trametinib, Enco-Bini. And what comes up a lot in clinic is, do you still need to be on the treatment or not? And I don't know the answer to that either, other than to say, and maybe this would be an interesting thing to talk about. There are data sets out there where treatment has been stopped for people who have been on BRAF targeted therapy for long periods of time. And my takeaway from those has always been that there are some people in whom you can safely, quote unquote, safely stop treatment and the melanoma won't progress. But my biggest concern here is the people where you stop treatment and the melanoma does progress. And then my fear there is that if you stop treatment, let's say the melanoma progressed 3-6 months later, whatever, my fear would be that if you start them back on the treatment again, that you might not get the disease under control. So for me in clinic anyway, for people who are generally tolerating treatment pretty well, by definition, because they've been on it a long time, they wouldn't have been on it a long time if they weren't tolerating it quite well. It feels very difficult for me to stop treatment if there's any kind of significant risk that the disease might progress and we might not be able to get it back under control. So that's how I've been practicing. But I have to say, it doesn't feel like we've got great data in this space. But I'd be very interested in what you thought.
I have loads to say about that. And I fully agree with everything you're saying. It remains a challenging area to know what percentage of patients we're curing. I think our instinct wants to tell us it's less than with checkpoint inhibitors, but I can't put my finger on some actual numbers here. Now, maybe this 7-year data is one data set where we can do that. That's number one. Number two, I guess this is what I was sort of mentioning. If the MEK inhibitor is not doing the heavy lifting, if the heavy lifting is the BRAF inhibitor, the MEK inhibitor is allowing them to stay on the treatment longer or better with less toxicity, this is just a side question, but does it need to be priced like a efficacy drug? These drugs are very expensive to patients and their insurance. Can we get a break on what the MEK inhibitor is really contributing here? Obviously that's not for us to answer, but the point is, we have had this chat. I remember you talking about on one of these episodes the patient who had terrible toxicity from continuing checkpoint too long, that the patient had gotten into CR and you felt horrible. They were in hospital for a year. And we have less of that concern with long exposure to targeted therapy because, those side effects, while they can happen, are rarely as difficult to get under control and so forth. So exactly, I agree with you. When somebody's doing well on BRAF MEK and we're in CR and we're not sure if pulling the finger out of the dam is going to cause the dam to break, I sort of just don't rock the boat. It's getting reimbursed or it's getting covered and the patient's tolerating it well. So what that screams to is we need the biomarker. So we know the BRAF oncogene is immune suppressive. It has the oncogene itself stops T cell infiltration. You start inhibiting BRAF, the oncogene, and you get an influx of your T cells. You then, those T cells then move on to the lymph nodes for education and onwards. So at some point, when has that in a way, there's an indirect education to the immune system when you give a BRAF MEK inhibitor. It's not immunotherapy, we all agree. But the thing that's likely giving you long-term cures and benefit here is immune education. So then in that case, what is the biomarker? When can we determine that somebody now has circulating T cell receptors against their melanoma from targeted therapy or immunotherapy, and therefore you can stop said therapy? I mean, we're desperate for that biomarker, whatever that looks like. So that's key. And then I think the other things that come to mind are, maybe I captured everything you said there. I'm going to take us slightly away now, which is I like this idea of time to next therapy. And in the presentation, I remember Dirk did it at ESMO 2023, and I think Reinhard presented it at Bridge 2023. I didn't go to that one, but I certainly saw the recording. And they basically have a slide in there of time to next therapy. And we can fact check this, but I believe that the takeaway is that your time to next therapy is longer on the combination in this Columbus 7. So that speaks to, I've had a little pain with PFS in my life because the S in survival is from competing risks often, the death from other risks. And so what I like to really know is how long have we controlled their disease? Time to progression or time to next therapy is a nice way to look at that. I think combination gets us there. One of the things in these long-term follow-ups, I've said to you, I don't want any opportunities lost for us in clinic. So now you and I both have patients on these drugs long-term. We've just said it. We don't tend to take it away. But what are we doing in terms of decreasing risk of CNS disease? Are we seeing that combination does that better than single agent? Are we seeing that? I would have liked to have seen something about maybe development of CNS or, something like that. That's an opportunity. That's partly what you mean, I think, when you say, when we take away the drug, if that cancer comes back, that melanoma comes back, we're particularly worried about it coming back in a place that becomes very difficult to get it under control, the brain. So that's that. And then I think the last thing I would say is just about tox, which is the tox here in the combination. I'm not even sure if it's in this paper, but I know it was in that presentation. The tox here in the combination is higher than in either monotherapy arms. So we can't necessarily dispute that, although maybe you would have argued this MEK inhibitor is making it easier to tolerate. I would have expected less tox in the combination. Again, we can fact check it from the table that was in the presentation or in the supplementary, but ultimately it was mostly GI toxicity, nausea, vomiting, that kind of stuff. It wasn't anything that, is necessarily that hard to get a hold of. Maybe the last point is what you said is like, what are the favorable characteristic responses? That's supplemental figure S3. That's, as you say, it's the things we think about. It's LDH, it's low number of organs involved, etc.
Yeah, no, all agreed. I mean, several points. I had an idea actually. I mean, you're exactly right about the biomarker, and wouldn't that be great if we did have something that we could use? I also think, for what it's worth, this is all speculation, that it's likely that these people are getting long-term benefit have had some sort of immunological impact of the treatment. But you know what I think we should do? Ask someone really smart. So Tony Rebus. So when we have our podcast with Tony Rebus, we'll ask Tony, because he'll have some good stuff to say about this. I must say I'm surprised. I find Encobini and Abtram, for their record, generally to be extremely well tolerated. And I've got lots of patients who are on both of those combinations in the really long term. And most of them, if not very much, almost all of them, are pretty much leading normal lives. So it's very interesting to see in the trial that doesn't seem to be reflected. And then the final kind of thing, gone.
Well, I was going to say to that, but keep that final thought in your head. I think in a trial, we do something that we don't do in the real world. I don't do it in the real world, but in a trial, you know what we ask patients to do? Bring me your bottles, and we're counting your pills. So you know what that builds in? That builds in a sense of compliance. Oh, I better, either you're smart enough to toss away the pills you forgot to take, or you leave them in the bottle and somebody says, oh, you missed a few days. So there's a compliance check that we do on trials. We don't do that in the real. I don't ask people to bring in their bottles and let me count. And we know this from breast cancer data. You look at tamoxifen. Of course, that's in the adjuvant setting, not the same as being metastatic and having the cancer right there. But the compliance with tamoxifen in adjuvant breast cancers shockingly low. It's something like 50% compliance, with taking it every day. I mean, as somebody who takes thyroid and blood pressure medicine, I can tell you I'm about 50% for the week, and I know better, right? I mean, the pill sorter is there and I know better. It's just somehow I even forget. So I think in the real world, maybe patients are also tolerating it better because the compliance is slipping a little bit. It's all speculation, who knows? But anyway, that's a thought. So on to your final thought.
No, I mean, my final thought was going to be, what should we be doing? Should we be doing anything different in terms of monitoring in these people who've really been on these treatments for long periods of time, over 5 years? And I have to say, we don't know much about the long-term toxicity. But what I've tended to do, actually, the thing that worries me most, honestly, is cardiac toxicity. I'm a bit obsessed about this anyway. So what I've been tending to do where I can is send patients like this for what you might call a cardiac MOT kind of checkup, as it were. Because they're at 5 years, they're doing really well. We know that both BRAF and MEK inhibitors can have cardiac toxicity. I mean, I'm mainly obviously thinking about arrhythmias there, and to some extent ejection fraction issues with MEK inhibitors. But, for these kinds of patients, it doesn't hurt, I don't think, this may be a counsel of perfection, but it doesn't hurt to have a cardiac checkup. So they'll probably get some baseline tests done, they'll get their cholesterol done, their blood pressure, all this sort of stuff. Most of them probably won't have any kind of invasive testing, but I quite like a cardiologist seeing them and saying, yeah, this is fine. And then if they do want to do invasive testing or follow them up, then great, that's fine with me.
Well, maybe I should ask you, when do you bring them in? Because, I'm sort of I scan the inside when I scan the outside. I think of doing things like thyroid testing for immune checkpoint inhibitor when we do the scan. I think of things like doing a ejection fraction assessment or EKG when we do the scan. So I have a long-term patient on BRAF MEK. I'm still doing those at the time I'm doing the scan. But how do you continue doing that type of cardiac surveillance, and or when do you hand the baton to a cardiologist?
No, so in routine practice, in people who don't have any cardiac comorbidity, I do not do routine ECGs. I don't do routine echoes. And so they would only be done if we had specific cardiac concerns, which will be driven by symptoms most of the time. So I'm not doing that on my routine practice, and I haven't really ever done that. And so cardiologists would normally only get involved with our patients if they've got symptomatic issues. But this is kind of the point I'm making. I'm talking more about kind of screening type of strategy for the people who've been on long-term treatment. And we've talked about this before. There might be reimbursement issues. There might be all sorts of other issues here, because once you start getting into screening, sometimes it sort of, rings different bells, shall we say. But and I'm not saying I'm right about this. I just don't think we know the answer, and maybe I'm being too cautious, actually.
Yeah, very nice. Well, that's great. That's a great conversation about Columbus, 7-year data on targeted therapy. Anything more to say, you think? I mean, obviously, job well done to the investigators here. Mostly, I think this was a purely European study. So kudos to our mainland European colleagues. I'm not sure I saw a UK name on there. So I'm giving shout out to them.
No, I'm not sure it was done. No, I'm not sure it was done. Yeah, no, very nice. Good to see long-term data as well. So congrats. Nice paper.
Excellent. All right. Well, thanks.
Thank you.
Hi, everybody. Let's do a fact check now for the Columbus study, Columbus 7, as I've been referring to it. Before we start that, James, this was the episode where you were telling us about why you got into oncology and how you got into it. And it was actually just a really beautiful, moving story. It turns out it's, there's a whole trajectory you can trace to this, and it's not just a simple, I studied it, I liked it. There was a whole trajectory, but I thought it was really lovely. And I, in the moment, probably didn't say what a great story that was. And that's probably been impactful for a lot of people to hear that. So good on you. I was trying to get the hearts to come out again.
Yeah,
there
I
you
think
go. I know.
Oh, there we go. You can actually do it to order. I'm actually impressed. Owen will be disappointed now because he thought he was special. But that's
Well, I mean, your story was pretty special, so it's not a one size fits all heart. All right, so Columbus 7. One of the things I was mentioning is that the data was presented at ESMO 2023. Dirk Schaddendorf had a poster, and then it was presented in December, a few months later. And I was talking about a potential time to progression analysis that they had done. But as it turns out, it wasn't quite time to progression. It was an analysis they called time to end of next line of treatment. So it was the time from randomization. Wow, there's a big Pepsi vending machine going by right now. It was time from randomization to the end of the next line of treatment. So another way we often think about this is we often call this PFS2. So the time from not your first progression, but your second progression to PFS2, they called it time to end of next line of treatment. That's fine to say it that way. And I think as you look at it, numerically, it's highest in the combination dose, but it's quite close, meaning it's not far off in the encorafenib monotherapy. So the numbers we're talking about here is 21.2 months versus 19.3 months encorafenib monotherapy versus 12.5 months vemurafenib monotherapy. So, once again, it's interesting to see that this lower dose of encorafenib is approximating where we are with combination therapy. But anyway, and then we were talking about toxicity. You and I had just peeked at a little bit of the toxicity and discontinuation. If you say something.
Yeah, so just looking at this from the poster as well, table 2, I have to say I'm pretty surprised, actually. If you look at the top part of it, treatment emergent AEs leading to discontinuations, almost 20% for the combo, 18% for vemurafenib, 16% for encorafenib. Very high, certainly for the combination. And I have to say, in my clinical practice, I've discussed this before, the number of people on encobini or dabrafenib and trametinib, for that matter, who need to discontinue treatment is really much lower than that. And I would say probably well under 5%. So a bit surprised by that. And also when you look at the breakdown of TEAEs, which is underneath, you can see, I suppose, that the arthralgia is noticeably better for the combination versus the other two arms. But actually, there's a little bit more GI toxicity there. So again, I was a bit surprised by that, but I would make the point, I think, in clinic that actually it's the arthralgia that sometimes causes patients trouble. So that's important. It doesn't feel to me, in practice at least, that GI toxicity is a major issue. And then I think my final point, without wishing to be too critical, is that, and this partly comes from my experience in kidney cancer, where we've been using anti-VEGF drugs chronically for probably 15, 20 years now, is just reporting out all grade and then grade 3, 4, I think isn't really great from a patient perspective, because sometimes by definition, this is 7-year follow-up. Patients are on these drugs for really, really long periods of time. Having a grade 2 toxicity for a long period of time is not trivial. So I have to say that I think in this kind of situation, and ideally always, I'd really want to see the tox really broken down properly into different grades, because I think that helps you understand it better. So those were my sort of thoughts there on the tox.
And I think I saw in the manuscript, I could be wrong, I could be getting another long-form manuscript confused, but I think I saw in the manuscript they do try to do this, where they talk about prevalence and incidence. So the prevalence of tox that was late emergent, so that came on in these later years, versus the incidence. Now that I'm saying it, I'm wondering if I said that inverted. Okay, we'll do another fact check at some other point about prevalence.
Fact check of the fact check. We like those.
We do. But it was basically the idea of what toxicities were still lingering at 7 years, were still prevalent at 7 years, versus new incidences of late tox, so on and so forth. So I think they do it, but they don't put as fine a touch as you say. And as we say, this is now we're practicing in the real world with this. I need to know even the low grade toxicities that are still there that might be of, impact to the patient. So
well, I would say often are an impact, and this is absolutely a quality of life issue. So it's actually a really important thing in the clinic. But there's some serious background noise there.
I know. I'm not sure if this episode is going to work after all. I'm going to have to find a more suitable place.
Let's see.
Well, thanks so much. Let's end this. All right.